Pulse oximeters are tremendous devices. We use them all the time in our clinical practice. In the first tutorial, I discussed oximetry, the measurement of SpO2. In this tutorial, we're going to look at the pulse and the pulse waveform and why the pulse oximeter is a tremendous device to look at cardiovascular function and blood flow. Fundamentals of Anesthesiology and Critical Care, presented by me, Pat Nelligan. This is a series on monitoring gases and vapors, and we're talking about monitoring oxygen. This is the second tutorial of 2 on pulse oximetry. Welcome back. Previously, we looked at the basic principles of pulse oximetry and light absorption, how the SpO2 is derived, the different types of pulse oximetry sensors, and pulse oximeters in action. In this tutorial, we're going to look at how pulse oximeters measure pulse. We're going to briefly discuss reflectance pulse oximetry, pulsatility index, and how pulse oximeters malfunction and how to troubleshoot them. So far, we have looked at the oximetry aspect, but pulse oximeters measure more than SpO2, and importantly, cannot measure oxygen saturation without the pulse. So let's look at that. The word plethysmography is used to describe the pulse waveform. It's usually shortened to the word pleth on monitors, but most of us refer to it as the pulse ox trace or equivalent. When the heart contracts in systole, a volume of blood is ejected into the aorta, and this expands the blood vessels sequentially as a wave that passes all the way to the capillaries and then dissipates into a lake of venous blood on the far side. Arterial blood is pulsatile, venous blood is not. The arterial component is the pulsatile signal. It changes with each heartbeat. Venous blood and the surrounding tissues stay constant. The pulse oximeter captures both a pulsatile or AC alternating component or current and a non-pulsatile DC direct component or direct current signal at the 2 wavelengths that are measured by conventional pulse oximeters. A key thing to understand is once the oximeter is placed, it does not actually stay stationary. It almost imperceptibly moves outwards and inwards with each pulse. Here is a boring bit for the next minute or so. Don't worry, it'll lighten up again. The key scientific concept behind pulse oximetry is the Beer Lambert Law, and that states that the absorbance of light is determined by how strongly hemoglobin absorbs light at a given wavelength, the concentration of hemoglobin, and how far light travels through the tissues. The transmitted light intensity is determined by this complex equation. But to keep this simple, in living tissue, the path length and effective blood volume changes slightly with each heartbeat. Tissue expands. The oximeter separates the DC component, that's constant absorption from skin, bone, venous blood, and capillaries, and the AC component, the pulsatile absorption due to arterial blood. In the first tutorial, I discussed the AC to DC ratio. This is based on the ratio of AC to DC absorption at 660 divided by the AC to DC absorption at 940. From OR is derived the oxygen saturation, the SpO2, using a calibration curve or table. The resulting curve slopes downwards. Higher OR values correspond to lower oxygen saturation levels. That is because there is higher than usual light absorption at 660 versus 940. With each arterial pulse, the distance between the light source and the photodetector is increased. The distance that the light has to travel increases. So with the systolic pulse, there is an increase in blood volume to the finger. That results in increased light absorption and reduced light at the photodetector. With the diastolic pause, there is reduced volume going into the finger. As a result, there is decreased light absorption and increased light being detected by the photodetector. When blood flows into the finger, it swells just a little. And due to the device's ability to separate out the AC and DC components, a Pleth waveform is produced. Once you have that waveform, all kinds of hemodynamic measurements can be made. Let's look at some considerations about measuring the SpO2 and the waveform. Conventional pulse oximeters use transmission sensors. Probes can be placed on the finger, the toe, or the earlobe. The finger is the most reliable because it pulses more than the earlobe. But the earlobe records the saturation quicker than the finger. Below 90%, accuracy of the pulse oximeter falls significantly, and the accuracy is poor below 80%. Now, anyone who has ever worked in the operating room, the ED, or the ICU has seen a patient go from pink to cyanosed very rapidly. Cyanosis becomes visible when there is more than 5 grams per deciliter of deoxyhemoglobin present. Hence, in anemia, there may be a low SaO2 but no discoloration. In polycythemia, the SaO2 may be normal with cyanosis. Cyanosis reflects changes in venous and capillary oxyhemoglobin saturation. The skin color reflects deoxygenation first because there is a delay to measurement of arterial blood. So that cyanosis is the veins and the capillaries. When the blood flows all the way around again, the blood in the arterial side becomes deoxygenated and the pulse oximeter picks it up. So there is a 30-second delay before you see the saturation drop. This graph demonstrates the delay between the onset of cyanosis and the fall in the SpO2. Remember, pulse oximeters have to filter out ambient light, noise, and movement. Most devices average readings over several heartbeats. Consequently, there must be a lag in most situations, and that can be up to 30 seconds of lag time, depending on where the probe is located. On the earlobe, it's shorter. On the big toe, it's longer than on the finger. Sometimes it's not possible to place a standard pulse oximeter on a patient. For example, a patient with severe burns, and one has to find some other part of the body from which a measurement can be taken, and reflectance sensors were developed for this purpose. Instead of standard probes that transmit light through tissue conductance, reflectance probes detect light that is reflected off the tissue. The light emitter, the LED for red and infrared, and the photodetector are on the same side of the skin surface. So we have our probe that is attached, for example, to the forehead. There's a red LED, an infrared LED, and a photodetector. This, of course, is attached to the signal processing unit that has a display. The signals are sent from the device, reflect off the skin and tissues, and are detected by the signal processing unit. The data looks exactly the same as the finger oximeter. So reflectance oximeters are really useful in situations where a good signal cannot be obtained from a traditional device. The finger probe dislodges during a case and the hand is inaccessible and you're not getting a signal from the earlobe, or flow is low. They're also really versatile. They can be put on the wrist, the arm, the chest, the foot, etc. There's less motion artifact with these devices, and they can be used for 2D mapping, for example, of wounds, in particular skin grafts, where you want to look at the flow of blood into that graft site. So think about these devices for your clinical practice. Now, let's move on and look at the problems with pulse oximeters. These can be listed as follows. The most common problem with pulse oximeters relates to hypotension or hypoperfusion. There's issues with anemia and skin pigmentation, light artifact, motion artifact, nail polish, and abnormal hemoglobins. The most common problem that I encounter in my clinical practices is the rookie mistake. If the blood pressure cuff that cuts off blood flow intermittently is placed on the same arm as the pulse oximeter reading will intermittently fall, causing the anesthesiologist to have recurrent anxiety attacks every time the saturation alarm goes off at around 90% every 3 to 5 minutes. So unless you absolutely have to, please put the pulse oximeter on a different arm than the blood pressure cuff. Obviously, if the patient is having surgery on one of their arms, you can't do that, but you can always place it on the toe or the earlobe. With hypotension, there is a typical picture. The patient is breathing spontaneously under anesthesia with a good tidal volume, inspiring more than 30% oxygen. The saturation is measuring 86% with an OK waveform, and that's puzzling. Why is the saturation so low? And then the BP cuff cycles and the blood pressure is 76/45 or equivalent. In this situation, the low SpO2 reflects poor flow. And this happens quite commonly in the operating room, particularly not long after induction of anesthesia, where the patient has had a major vasodilator, propofol, they've had an anti-adrenergic drug, an opioid such as fentanyl, and you've started positive pressure ventilation. But a lot of the time these days, when I look at this pulse oximeter trace in the hypotensive patient, the waveform looks okay. And why is this? If you look at review articles on pulse oximeter waveforms, this is one from Critical Care in 2015, it produces a picture that looks like this kind of flat-looking trace. And if you went back to the 1990s, when we had a patient in the operating room, if the patient was hypotensive, then the signal from the pulse oximeter was heavily damped and looked like this. But modern machines amplify the signal such that in hypotension it may look absolutely normal. But I want to draw your attention to this number that may be visible on your monitor screen that you have likely been ignoring. This is the Perfusion Index that is labeled PI or PERF. It is a number that purports to give us information about the quality of perfusion in the location of the probe. Poor perfusion is caused by hypothermia, hypovolemia, vasoconstriction, vasopressors, heart failure, etc. And this number varies by manufacturer. Everyone uses a different range, which is kind of confusing. It's derived from the division of the AC component versus the DC component. So if the pulsatile AC component of the Pleth signal is 30% of the non-pulsatile DC component, then the perfusion index is 0.3. If the AC component is greater than the DC component, then the perfusion index is greater than 1. This is a chart with the different manufacturers and their devices on the left-hand side and the level at which the perfusion index is considered poor, acceptable, or optimal. In the hospital that I work in, we have Mindray monitors in our operating rooms and Philips monitors in our ICU. Note that these numbers are very different. For Mindray, if the perfusion index is less than 0.3, that's considered poor, and greater than 1 is considered optimal. Conversely, for Philips monitors, if the PI is less than 0.5, that's considered poor, and if it's greater than 1.5, that's considered optimal. This is a series of patients who were attached to the Philips monitor. The top patient had a perfusion index of 0.28, so that's really low, and this is very poor, and this patient is hypoperfusing. The middle patient has a perfusion index of 0.8. That's in the OK range, as it is for the patient in the bottom screen, whose perfusion index is 1.2. These are different screens on the Mindray monitor, and you can see that the top trace isn't great and the perfusion index is 0.56 and it is colored yellow. It's okay, but it's marginal. If it's less than 0.3, that color would be red. The second trace is 1.74, and that's considered very good, satisfactory, possibly optimal. But the bottom two traces are stellar, 8.52 and 11.9. And the Mindray monitor gives values up to 20, and this can be a little bit confusing because that seems like a very large distance from our patient with 1.74. For what it's worth, this is me today. On the top is the data from the Mindray monitor with different probes. The left was with a PEG probe, the right was with one of the sticky ones, and you can see my perfusion index went from 1.82 to 4.96. On the bottom picture, I was using a Philips monitor with the rubbery probe, and my perfusion index was 1.2. So this can be really confusing, so I'm going to try and keep this simple. In general, if the perfusion index is less than 0.5 for any monitor, that's bad. And if it's more than 1 for any monitor, that's okay. Now let's move on. One of the things that sinks the heart of an anesthesiology nurse or assistant in the operating room is the appearance of a Goth in the holding bay, because inevitably they have these dark varnished nails. The motto here is that pulse oximeters hate Goths. That's people who love the cure, Sisters of Mercy, etc. Nail polish affects pulse oximetry readings and reduces it by 3 to 5%. For red, pink, or clear nail varnish, there is really minimal impact, and you'd never ask those patients to take the varnish off. But dark colors are worse in this order. The worst is blue, followed by green, black, and purple. Skin pigmentation results in overestimation of the saturation versus patients who have pale or fair skin. Another problem that has been seen with pulse oximeters since they were introduced into clinical practice was the degeneration of a nice pulse waveform into a jingle-jangle line. But this ugly Pleth trace is associated with motion artifact. Motion and movement significantly impact pulse oximeter readings. And over the past 25 years or so, manufacturers have been working really hard to find ways of reducing motion artifact. All have proprietary signal extraction technologies or algorithms to reduce the artifact. Masimo use a technology known as signal extraction technology. Covidien use Oximax, that's AI-based noise reduction. Tatex Omida, which are a GE brand, use TrueTrack. Mindray use IPM signal processing. All of these work, to me, almost interchangeably as ways of improving the trace, but motion artifact is almost impossible to eliminate. Diathermy does affect pulse oximetry readings due to electrical interference or electromagnetic noise contaminating photodetection and signal processing. Modern oximeters' signal processing reduces this, and they include high-quality shielding, but you do need to be careful with probe placement. With regard to anemia and blood loss, remember that pulse oximeters measure the ratio of light absorption by oxygenated versus deoxygenated hemoglobin. In anemia, the total oxygen carrying capacity is lower, but the SpO2 may remain normal. This is also true of blood loss. But in a situation of blood loss or anemia with hypoxemia, the pulse oximeter generally underestimates the true SaO2. So if you have someone who is bleeding in the operating room or the ICU and their saturation is reading 88%, it's a bit like that situation where the blood pressure has dropped. It gives you a false low reading. Dyshemoglobinemias. These are more common than you might imagine. Carboxyhemoglobin absorbs light at similar wavelengths to oxyhemoglobin, and as a consequence, in patients with carbon monoxide poisoning, the SpO2 and the SaO2 is overestimated. Methemoglobin is unable to carry oxygen effectively, and the pulse oximeter tends to read 85% regardless. Fetal hemoglobin does not affect SpO2 but shifts the oxyhemoglobin dissociation curve to the left, increasing affinity. There are situations where the waveform may be problematic. Tricuspid regurgitation, where there are giant V waves on the CVP, or other causes of venous pulsatility impact pulse oximetry readings by erroneously lowering the SpO2, leading to signal instability. Be very careful if the patient has end-stage renal disease and has an AV fistula. Edema increases tissue thickness and scatters the signal, weakening the Pleth waveform amplitude, and there is unstable SpO2 readings. So you need to look for a finger or a toe or an earlobe that is not edematous when placing your probe. Now let's review this tutorial. This was tutorial 2 on pulse oximetry. We looked at how pulse oximeters measure pulse. We looked at reflectance pulse oximetry, the pulsatility index, and how pulse oximeters malfunction. In the upcoming tutorials, we look at how oxygen is measured on a blood gas machine. We look at the PaO2 and how it's measured, the SaO2 and how it's measured, and co-oximetry and other hemoglobin species. I guarantee you'll learn something.